Hi, everybody, and good morning. Welcome to Our Health to Hold, a community-based webinar series that helps us to highlight the great work of all of our coalition partners. My name is Jenna Sistad, and I'm the project manager of the Ocean Monmouth Health Alliance, which is our region's cancer and chronic disease coalition. We do a lot of prevention work, educational campaigns, and we partner with all of our amazing coalition and community partners to implement this series on a monthly basis. We thank you for being with us today. And this month, February, is not only American Heart Month, but it's also Cancer Prevention Month. And so we are raising awareness about all types of cancer preventative screenings and education. And so today we have Ryan Moulton from Rutgers Cancer Institute and Screen NJ to talk about the cancer basics with us. And so thank you, Ryan, for being here. We know that we're going to go through a little bit of a pre and post survey. So if you could just hang in there with us and take part in those surveys, I think it would be helpful to Ryan and his team. And yeah, I'm going to turn it over to you, Ryan. Thank you for doing this with us.
Thank you, Jenna. I appreciate you having me today, and thank you guys for spending your morning with me. So just to introduce myself, my name's Ryan Moulton. I work as what we call a community cancer control specialist, aka a health educator with Rutgers Cancer Institute's community outreach and engagement team. So today I'm going to be giving you guys a little overview of cancer basics. We know and we understand cancer can be a very overwhelming topic. It touches home for many of us in the United States. And my goal is just to give everyone here a better understanding of cancer, how it starts, go over some of the things you can do to protect yourself or reduce your individual risk for cancer, and also talk a little bit about those cancer screening guidelines so that you can understand when you should be getting your cancer screenings and when your family should be getting your cancer screenings to reduce, poor outcomes in cancer diagnosis. So just before we begin, I do have to remind everyone that the information contained in this presentation is not meant to be a substitute for medical consultation. So physicians should always be consulted for any health problem or medical condition. With that being said, when it comes to asking questions, unfortunately, I'm not permitted to answer any questions that are pertaining to giving out medical advice. However, I just want to put it out there. If you have any questions throughout the presentation, I encourage you to raise your hand using the Zoom function, or you can simply put them in the chat and I'd be more than happy to address them. Just cannot be anything with medical advice. All right, so before we get into the good stuff, I have a pre-test for everyone. So the pre-test questions are a way for us to kind of test what you already know about cancer and cancer 101, so to speak. So we should have a poll that will be launching very shortly. It's just 3 simple true or false questions. And what we're going to do is review the answers at the end of the presentation with a post-test. And the post-test is going to be the exact same as the pre-test. And it's going to kind of serve as a way to evaluate what you learned from the presentation, whether or not any of your answers changed based on the information received. So I'll give you guys a couple seconds to answer that, and we'll get into the presentation.
Ryan, can you see that it's launched on your end? I see some people have participated so far.
Yes, I see it's launched on my end.
Okay.
I'm gonna exit out of it.
Okay.
So Jen, you can actually just let me know when you have, majority compliance, and then
Yeah, I would like to see, right now we have 76%. I would like to see at least one or two more, because you and I both can't take it. But yeah, if one or two more took it, then we can. Okay, winding down this poll here. I'm going to end it if that's okay with you, Ryan.
Perfectly fine with me.
Here we go. We got that last person going in. Perfect. Thank you to everyone for participating. I'm going to end it now.
Thank you, everyone. I appreciate it. I promise you're not getting a grade. So, and like I mentioned, we'll be going over the answers at the end.
You want me to share the results with you, Ryan?
Not right now. No worries. Okay. I appreciate it, though. Thank you. So this is what basically we're going to be doing and talking about today. So we break this presentation down into 3 parts. So part 1 is going to talk about those basics of cancer, what it is, how it starts. In part 2, what we're going to do is review the screening guidelines and the screening basics for what we call preventable cancers and talk about the importance of early detection. And then in the final part, we're going to talk about those cancer risk factors and then cancer risk reductions, things that you can do to reduce your individual risk for developing cancer. So just to break down part one a little bit further, we're going to talk about what cancer is, why we should care about cancer. So looking at those statistics that show the true reflection of the cancer burden. We're going to talk about what causes cancer and then briefly touch on cancer development. We'll also review the difference between benign and malignant when it comes to tumors. We'll talk about what metastasis is, treatment options available for cancer, and then lastly, the importance of early detection through screening. So just to break down what cancer is, and like I mentioned in the beginning, I am very aware that many of us have either personal or indirect experiences with cancer, whether that be a family, a friend who has had a diagnosis of cancer. So when we define cancer, we don't really think of it as one cancer. So we think of it more as a collection of related diseases that can virtually start anywhere in the body. What we know is that with cancer, you have your normal healthy cells. There are billions and billions of cells all around our body. A lot of these cells have specializations. They have a special purpose in the body to carry out specific functions. What we know is that when these normal cells die, when they're damaged and when they're old, they're programmed to undergo what we call apoptosis, cell suicide. So they die off. Cancer cells are unique in the sense that they don't die when they should. So when these normal cells, they get damaged, they grow old, whatever happens, they get some sort of mutation. Cancer cells are not dying off like they're supposed to. And what they do instead is continuously form, rapidly grow and divide, and ultimately end up with the formation of a solid tumor. Most cancers do form solid tumors. So that is where we kind of see the first presence of cancers when you have that first normal cell that's transformed, that's mutated, that grows old, and it doesn't undergo that program to commit cell suicide and just virtually ends up progressing, rapidly growing and dividing, and ultimately forming in the formation of those solid tumors. So why should we care about cancer in our community? So for starters, cancer is actually the second leading cause of death in New Jersey and in the United States as a whole, and that's only behind heart disease. So we know that in terms of lifetime risk, about 1 in 2 men, and 1 in 3 women will develop cancer during their lifetime. So when we look at some of those key statistics, we look at the American Cancer Society, and from what we saw in the data in 2023, there are an estimated 56,150 new cases of cancer in New Jersey. This is slightly higher than we saw in 2022. And then we know that the top sites for new cancer diagnoses, those being the most commonly diagnosed cancers, are prostate, breast, lung, colorectal, and skin. And these are actually those sites. Not all of them, but the ones that our program focuses on addressing the most, because obviously there is that cancer burden, and we want to make sure that we're reducing late-stage diagnosis of these cancers. We consider these cancers that are listed here preventable, and we also consider them treatable, especially when they're caught early. We see very good outcomes in patients when we do catch these cancers at an early stage, and we'll talk a little bit more about why that is later on. So when it comes to, pinning down what specifically causes cancer, it's really, there are many, many different things, various causes of cancer, and some of the factors that are listed here can put us at that increased risk for developing cancer. We're going to break down these factors into 2 categories in the next slide, but just to kind of introduce those basic concepts of what can cause cancer, we have hereditary risks. So this would be familial risks, cancers that quote unquote run in the family. You also have chemical exposures. This can be things like UV radiation, sunlight, using tanning beds. We know that there are certain viral and bacterial infections that can increase your risk for developing cancer. A big one is smoking, firsthand smoke, secondhand smoke, using any sort of tobacco product. We know this will increase someone's risk for developing cancer. And then sometimes cells just don't divide properly. During the cell division process, we see errors, we see mutations arise, And sometimes that can just be random and ultimately lead to the development of cancer. In all of these instances, the major driver is that's turning these normal cells into these cancer cells are changes that are happening at the genetic level. And so the next few slides, like I mentioned, are going to differentiate between those two different types of risk factors. And we break these down into hereditary risk factors and sporadic risk factors. And if you're not familiar, just thinking about a risk factor in general, this is just anything that can increase your chances of developing a disease. If we think about cancer risk factors, those are things that obviously increase your risk of developing cancer. So like I said, we break these down into hereditary and sporadic risk factors. Hereditary risk factors are those, risk factors that are essentially passed down from your parents. They may be passed down to your children as well. You can't necessarily prevent these genetic changes, but you can understand what cancers you might be at a higher risk for by understanding your family history. And if accessible, you can also get genetic testing to see if you have any mutated genes that are linked to an increased risk for developing cancer. Sporadic risk factors are those factors that are happening over the course of a person's lifetime that can work in conjunction with each other to actually increase your cancer risk. So we call some of these quote unquote modifiable risk factors just because you have the ability to avoid or change certain behaviors, certain lifestyle choices that you make that will increase your risk for developing cancer. Biggest example is smoking. No one is born with a cigarette in their hand. That is a behavior that people adopt over the course of their lifetime. So it's modifiable and it's what we'd call avoidable. When we think about a non-modifiable risk factor, this could be something like aging. Obviously, we're not able at this point in time to control, delay, or stop the aging process. And we know aging is a major risk factor for developing cancer. The older you get, the likelihood of developing cancer will increase. We call it a disease of aging for that reason. So talking a little bit more about those hereditary factors, one of the things we encourage people to do if they can is to use genetic testing services to find out if they carry any sort of gene mutation. So this would show you what cancers you may be at a higher risk of developing based on any inherited gene mutations. And a big one that comes to mind is that BRCA gene mutation, BRCA1, and that's linked to an increased risk of breast cancer and ovarian cancer in women, and also a slightly increased risk for developing prostate cancer in men. And we understand it's not always possible to know your family history, whether people have long distant relatives they don't know that have passed. We know it's not always possible, but it is important to know your family history if you can. You can talk to your family members about what types of cancer they know run in the family, and usually with hereditary cancers, we see commonly in the family the same site being diagnosed. So, for example, having 3-4 generations with a history of triple negative breast cancer could be indicative of a BRCA gene mutation. And then, you can always talk to your doctor about genetic testing if you know there are any cancers in your family that were diagnosed at a young age. Again, if you have multiple cancer types in one person, or if you have one of those instances where there's the same cancer type in many generations, if you have any unusual cases of cancer, family members that have had cancer, and if there are any racial or ethnic risks associated with cancer, we know there are certain racial groups that are more at an increased risk for certain types of cancers. I just want to highlight, though, when it comes to hereditary cancers, they only account for about 5 to 10% of all cancer cases. So people, oftentimes they'll say, I know cancer runs in my family. I'm nervous about that. And, while that is an extremely valid sentiment to have, it's more likely that sporadic risk factors like diet, lifestyle, things that, behaviors that you actually inherit from your family members just by your upbringing, choices you make that you adopt from living in, being in the same environment as family. These are usually the things that will increase cancer risk. So I want to talk a little bit more about those sporadic risk factors, and it's most likely, there's a combination of these sporadic risk factors that cause someone to develop cancer. Oftentimes, like I mentioned, people think cancer runs in the family. As we noted, there's only a small percentage of cases that are linked to hereditary factors, and the cause of cancer is more likely to be due to sharing those certain sporadic or modifiable risk factors, learned behaviors, instead of it being hereditary in nature. So these behaviors, what ends up happening is these lead to genetic changes that happen over a long period of time and lead to the development of cancer. This usually takes years and years to happen. So looking at the graph, you can see that some of the major sporadic risk factors would be things like tobacco smoking, excess body weight, using alcohol, being exposed to high amounts of UV radiation, having a poor diet, being exposed to different infections, and also a lack of physical activity. So what this is showing you is the percentage of United States cases in adults that are older than 30. It is showing you what sporadic risk factors are attributed to these cancer cases. And you can see there is a big disparity when it comes to tobacco smoking, kind of showing us that tobacco use is the highest linked sporadic risk factor to developing cancer. So it's one of those factors that is going to significantly increase your risk for developing cancer. And like I mentioned, cancer is not something that happens overnight. Cancer takes years and years to develop. So we consider cancer development as the 3 phases of carcinogenesis, which is basically a fancy way of saying when those normal healthy cells are transformed into cancer cells. So we break these down into 3 phases. Phase 1 is initiation, and this is where you have those first cells that start to mutate or change. It could be from DNA damage, it could be from errors in the cell division process, whatever the case may be. You have that first instance of mutation occurring, DNA damage, and then you move on to phase 2, promotion. So this is where you have the rapid reproduction of those mutated damaged cells. It's during this phase that we actually try to screen for cancer prevention. This is where we're trying to do things like those mammograms, those pap smears. We want to look for the presence of these abnormal cells before they become cancerous and before they progress, before they start to continuously rapidly grow and divide and spread to other parts of the body. So the goal is really to detect these cancers as early as we can in this phase before you have those tumors that start to grow and spread to other parts of the body. And that's essentially what we see happen in phase 3, progression. So this is the last phase in tumor growth. And this is when the tumor becomes more invasive, a lot more aggressive, and actually can start to metastasize or spread to other parts of the body. This is a very basic overview of the stages of cancer. So when we find cancer, when a patient's diagnosed with cancer, it's given a stage, and we break these down into 5 different stages. So in stage 0, this one is, where you have those abnormal cells that have been found. So you see there's the presence of these abnormal cells. They're not normal, but they haven't spread to other nearby tissues. So they're in the same spot where they experienced that original mutation or DNA damage. We call this in situ, which means in its original place. So the abnormal cells, again, they have not spread beyond where they first formed. And we actually consider in situ cells non-cancerous. So there's not cancer yet, but we kind of prefer to call it the precancerous stage, since essentially these cells can become cancerous and start to spread to those nearby tissues. And when I say nearby tissues, we're talking about on the same site. So it'd be like the original spot, the original tissue cells on the prostate. They end up becoming abnormal, experiencing some damage. When they're in situ, they're still in that same spot where they experienced the damage. And then as you progress up to stage 1, this is when they become cancerous and start to invade the surrounding tissue of the prostate. In stages 1 to 3, this is again where you have the diagnosis of cancer. Cancer has been found and the individual has gotten a cancer diagnosis. So essentially what happens is the number is going to represent the size of the tumor and whether the cancer has started to spread to nearby tissue and how much it's spread to nearby tissue. So obviously the higher the number, the bigger the size of the tumor, and also the greater the rate of spread to nearby tissue. How fast is it progressing and invading those nearby healthy tissue cells? Stage 1 is usually what we'd consider the early stage cancer, while stages 2, stages 3, those are the more advanced cancers that have started to spread and take over that surrounding tissue. And then in stage 4, this is what we consider metastatic cancer. So stage 4 is where you have cancer that's metastasized, which means it's spread to other parts of the body. This can include even distant, far away parts of the body, like, for example, colorectal cancer spreading to the lungs, things like that. And actually, just to highlight stages, it's very important we give cancer stages because this is what informs treatment plans for patients. This is what tells oncologists, okay, this is how severe this cancer is. What should be my action when it comes to giving this patient an individualized treatment plan based on the stage of their cancer, the severity of their tumor, and a couple of other different factors. So now that we have a better understanding, hopefully, of how cancer cells develop, I want to talk a little bit about how these cancer cells survive. What is keeping these mutated, damaged cells in our body? What is keeping these cancer cells in our body? Why don't we just get rid of them? So the thing with cancer cells is they essentially develop these specific characteristics that allow them to kind of go undetected in the body and essentially sneak past the immune system. So they're evading the immune system. And we'll go through each one of these one by one, these different characteristics of how these cancer cells survive. So the first one is proliferative signaling. And this is where you have an increase in cell growth signals, which is how you're getting that rapid growth and division of these cancer cells. They're growing at a much faster rate than normal healthy cells would because they sustain that proliferative signaling. And then cancer cells also have this unique ability to evade growth suppressors. So that is essentially what is allowing these cancer cells to grow without any control, without anything stopping these cancer cells and saying, oh, all right, we got enough. We don't need any more. Like we normally see with normal healthy cells, we have these growth suppressors that are signaling to these cells, all right, let's take it back a notch. You're all good. We have plenty of you in the body. Cancer cells essentially go without that command telling them to stop. So they just rapidly grow without anything stopping them from doing so. Then you have activating invasion and metastasis, which is when the cancer cells actually start to move to other parts of the body. This can be, distant parts of the body. This is where we'd have, stage 4 cancer. They're able to kind of spread around the body and move freely. And then another characteristic is their ability to enable replicative immortality. And this basically means that cancer cells can just keep making more and more cells. This is why you see that infinity symbol there. Again, and that's because there's nothing stopping them, and there's things that are encouraging them to grow at a much faster rate. Another characteristic would be inducing angiogenesis, which, to put it simply, means that cancer cells can actually make their own blood vessels and make new blood vessels. And this is what's feeding that tumor and allowing it to really thrive in the body. And then lastly, you have resisting cell death. And again, this is referring to that process of apoptosis, cell suicide. This is how the cells continue to survive, evading those signals that would otherwise expel that cell from the body as it really no longer serves its purpose. So again, one of those unique things about cancer cells is they actually have the ability to form their own tumor microenvironment. And this is essentially how cancer cells are ensuring their survival in our bodies. So cancer cells don't have any distinct specializations like our normal cells do in the tissues that they're developing in. For example, a tumor cell that's growing in the liver, it's not acting exactly like a normal liver cell would. Or if you had a tumor growing in the brain, it's not acting like normal neurons would act in the brain. The thing with cancer cells is they do have the ability to create their own tumor microenvironment, and they do this by influencing surrounding normal cells. And they're also influencing things like molecules, blood vessels. Remember, I talked about angiogenesis in the last slide. What's kind of amazing about cancer cells is that they can influence normal cells to create blood vessels that actually supply the tumor with blood, with nutrients, with oxygen, and this is what's allowing that tumor to thrive and grow in the body. So it really is kind of like a parasite. Before we go any further, I want to make a little distinction between benign and malignant tumor cells. So I'm sure some of you have heard this word before, benign. Benign tumors don't spread, and they're generally, when it comes to benign tumor cells, they generally don't grow back when they're removed from the body. And we usually consider benign tumors harmless in the sense that they're not cancer. However, benign tumors can actually start to grow very large. They can become life-threatening if they're in specific areas like the brain. The brain is a closed cavity. And so when you have a benign tumor, it will press on the sensitive tissue of the brain and actually start to cause damage and can actually even lead to death. In other parts of the body, like, for example, the abdomen, tumors have more room to grow because they're less restricted by the soft tissue that's around them. So having a benign tumor in the abdomen may not present as much of a risk as having it in somewhere like a closed cavity. Malignant tumors, so these are what we consider those cancerous tumors. These are the tumors that can spread to other tissue in the body. Cancer cells, like I mentioned, travel throughout the body via the bloodstream and the lymph, and they form tumors in other areas, especially when it gets to that more late stage aggressive disease. I've been using the word metastasis a lot throughout this presentation just to kind of make sure everyone understands. Metastatic cancer is cancer that spreads to other parts of the body. This again includes, nearby parts, distant, far away parts of the body. Metastatic cancer is always going to be called by its original or primary cancer. So what that means is, for example, in this image that you guys are seeing, we see that the original, or what we call the primary cancer, is colorectal cancer, so cancer in the colon. And what's happened is it has metastasized, it's spread to the liver and the lung. So we would call this metastatic colorectal cancer. We wouldn't call it liver cancer, we wouldn't call it lung cancer, we would call it where its primary cancer started. So metastatic colorectal cancer. And we would have to treat it as a stage 4 colon cancer. All right, so I want to move into a little overview of cancer screening. So as I mentioned earlier, cancer cells are, dividing rapidly, and abnormal cells, are growing throughout the body. And it's in these very early stages of cancer where we want to screen before these tumors start to develop even further and become more aggressive. So the reason why we screen when we do is for early detection. We want to find these cancers at a more treatable stage because we know that will improve outcomes for patients. Less harsh treatments, treatments that are more effective for early stage cancers. That is the reason why we don't want late stage disease. We also know that cancer screening will reduce mortality because when we detect cancer at an early stage, we're reducing the risk of dying from that cancer. Also, screening can prevent cancer recurrence. So we're identifying and removing those cancer precursors before they have the chance to develop into cancer, late stage, early stage, whatever the case may be. Think colonoscopies. You're going in there and you're actually scraping out precancerous polyps that otherwise, if left untreated, would progress into cancer. And cancer screening also reduces morbidity. We know that early stage treatment may have fewer side effects. Like I mentioned, may be less harsh on the body. So you're actually reducing the harm from that treatment on your body. So cancer treatment comes in many forms. And when I say many forms, I really do mean many forms. We're really just scratching the surface of cancer treatments. And, there are also hundreds of thousands of studies going on at different cancer centers across the United States investigating new treatments for cancer. Basically, the idea for treatment is that it's always going to be based on the type of cancer and also the level of advancement of that cancer. The most common treatments we see when it comes to cancer are surgery, radiation therapy, chemotherapy, and immunotherapy. So I want to talk a little bit more about those. So we'd consider both surgery and radiation as localized treatments. This means they're targeting that specific area in the body where cancer is present. Radiation therapy is a treatment that uses those high doses of radiation to actually kill cancer cells and essentially shrink down those tumors. And then surgery is actually going into the body, removing cancer contained in one area by scraping out that tumor, cutting out that tumor. So for example, let's say, if lung cancer is caught early thanks to screening, thanks to a low dose CT scan, in many cases, it can actually be cured by surgery. And this surgery would remove the tumor, and then you may follow that up with some radiation therapy, again, targeting the lung, that area of the lung where the cancer was present, just to make sure you're killing off any remaining cancer cells in the area. Then you have chemotherapy. This uses drugs to kill cancer cells. And then you have immunotherapy, which is helping your immune system fight cancer. Both of these treatments options basically target cells throughout the entire body rather than being a localized therapy or localized treatment. There are new therapies that we're seeing more of too when it comes to treatment of cancer. You have targeted therapy. This is actually targeting the changes in the cells that help these tumors grow, divide, and spread. You have hormone therapy. This is used to actually slow down or stop the growth of breast and prostate cancers that use hormones to grow. So estrogen, testosterone. You have stem cell transplants. These are used to actually restore blood-forming stem cells in cancer patients who have had theirs destroyed, essentially, by very, very high doses of chemotherapy or radiation therapy. And then you have precision medicine, which helps doctors to select a personalized treatment that is most likely to help patients based on a genetic understanding of their disease. All right, so now we're going to move into part two. So I'm just checking time here. So the following slides, what I'm going to do is review some of those screening guidelines for different types of cancer screenings, for different types of cancer sites. We're going to talk about breast, cervical, colorectal, lung, prostate, skin. Again, these are some of our priority cancer areas at ScreenNJ. These are the cancers that we see most commonly diagnosed in the community, and where we also see barriers to accessing these screenings. And I don't want to just sit here and tell you that, screening is good for cancer prevention. We all know that screening is good for cancer prevention. I just want you to leave here with a better understanding of why we screen and when we screen and how screening is most effective. How can we make sure that we're, taking the most from that opportunity to get screened? So we'll start with breast cancer. So we know breast cancer is the second leading cause of cancer death for women. And this is, again, a testament to why screening is so important. The guidelines here, we have two, one from the American Cancer Society and one from the U.S. Preventative Services Task Force. They differ slightly, but the main idea is that every 1 to 2 years appears to be the consensus in terms of how frequently a woman should be getting a mammogram. If someone's under 40 years old and has a first degree relative, so that would be a parent, a full sibling, or a child that has had breast cancer or currently has breast cancer, or is at a higher risk for a more aggressive form of breast cancer, what we would encourage you to do is discuss screening frequency with a healthcare provider, since it may be more often that the guidelines may recommend you get screened more often based on this family history, or they may recommend you start getting screened at an earlier age. And this would also be applicable if you have any genetic mutation that you've inherited that you're aware of that would increase your risk. For example, we know that women who have that BRCA gene mutation typically are recommended to begin screening at age 30. Just to kind of highlight, men were, also at risk for breast cancer, significantly less than women, but especially those men who have a family history of the BRCA2 gene mutation. And also we have a syndrome that we find in men called Klinefelter syndrome that can cause benign breast growth. And then, like in women, obesity will increase the risk for male breast cancer, again, due to the higher levels of estrogen being produced in the body. Talking about cervical cancer screening. So most cervical cancers can actually be traced to an HPV infection. We call this the human papillomavirus. However, it's important to note that not all HPV strains are linked to cancer, and not all abnormal cells that are found in the cervix actually become cancerous. The recommendation for regular screening is for anyone with a cervix from ages 21 to 65. So thinking about what that screening test looks like, we call this a pap test, a pap smear. So where's that on the cancer trajectory? So it's earlier than a lot of the other cancer screenings. Like I mentioned, they recommend screening beginning at the ages of 21. And it's early because it's checking for abnormal cells. It's checking essentially before cancer develops, those in situ instances. And this is how we prevent cervical cancers, because not all abnormal cells become cancerous. In most cases, they don't lead to cancer, but we want to make sure we're essentially monitoring the area, especially if that individual has HPV. Colorectal cancer screening, we know colorectal cancer is the second leading cause of cancer death in the US for both men and women. And with screening, we actually consider it to be one of the most preventable cancers we have, since studies have shown that screening for colorectal cancers and finding it in an early stage can significantly prevent those worse outcomes, including death. Reason being colonoscopies. Colonoscopies are what we consider the gold standard for colorectal cancer screening. Essentially, this is a procedure that looks inside of the colon and the rectum, and it's searching for those abnormalities, those cancers, and also those polyps. And this is considered, invasive. I can't speak on it. I've never had one, but I'm sure many of you have, had one or know someone that's had one. We know it's pretty invasive, and we know that the prep for it can be a little bit intense. Sedation sometimes is required depending on the person. But the good thing about colonoscopies is you're actually going in there and you're removing those precancerous polyps, essentially preventing the cancer from even developing. That's why we call it preventable. You also have other ways to screen for colorectal cancer. You have an FOBT, a fecal occult blood test, and this is checking for the presence of blood in the stool. This is, pretty simple. People will send in a stool sample, and then it will be examined by a doctor, and they're going to look for the presence of stool, which may refer to get you a colonoscopy. And then there are a couple of different other ways we screen for colorectal cancer. Just in the interest of time, I won't go over them, but nothing, again, is as accurate and as preventable for late stage cancer as a colonoscopy. You have lung cancer screening. We know lung cancer is actually the leading cause of cancer deaths in the US for both men and women. And we also consider it the most preventable cause of cancer death because of screening. So the screening guidelines are for people between the ages of 50 and 80 years old who have a 20 pack year history, which basically means if you smoked a pack a day for 20 years or any other kind of variation of that, like 2 packs a day for 10 years, whatever the case may be, 5 packs a day for 4 years, or if you're a current smoker, or if you've quit within the last 15 years and you're willing to undergo treatment, all of that in mind, then you'd qualify for a lung cancer screening. And the best way, the current recommendation for lung cancer screening is, especially in those high-risk individuals, is a low-dose computed tomography. We call this a low-dose CT scan. This is considered, again, that gold standard for lung cancer screening because it's been found to be the most effective method of detecting tumors before they spread to other nearby tissue of the lung. So a low-dose CT scan is essentially giving doctors a very detailed image of the lungs, and we know it's been shown to reduce lung cancer deaths in those who are considered, very heavy smokers. Because it can spot the cancer extremely early in those really early cases, or rather stages, before you have those symptoms develop. And this allows doctors to actually go in there and surgically remove the cancer. We know lung cancer has a very high cure rate when it's found early. And oftentimes, once those symptoms develop, it's generally too late. And that's why we really encourage lung cancer screening, colonoscopies, because cancer is tricky. Not often will you get symptoms if you're at a very early stage. It's not only until, you've progressed to a much later advanced disease where you start to have those symptoms appear. And that's especially the case for lung cancer. So we say to people, even if you don't have symptoms, which is often the driver for people to go and get screened, even if you're not experiencing any symptoms, it's always important to maintain that dedication to those recommended guidelines for screening. So prostate cancer screening in the United States, we know prostate cancer is the most common non-skin cancer in people with a prostate. It's the second leading cause of cancer death in men as well, and prostate cancer is found mainly in older men. It's very rare for men who are probably around my age to be diagnosed with prostate cancer. Um, Although we know the number of men with prostate cancer is pretty large, the most of the time, most who are diagnosed with it do not die from it. Just going back a little bit, we know the average age of diagnosis for prostate cancer is about 67. And we like to say that, again, most who are diagnosed with it do not die from it, but rather with it, because it's really one of those very slow growing cancers. And oftentimes, and if we could get into more about the guidelines, I'll talk a little bit more about that. But basically, um, oftentimes they don't even recommend you get screened after a certain age, 70, 75, because if it's caught at a very early stage, people are more often at an increased risk of being harmed from treating that very low risk prostate cancer than they would be to undergo treatment for it. Prostate cancer occurs more often in African Americans than it does in whites, and so we know African Americans with prostate cancer are more likely to die from this disease than whites with prostate cancer. And so, since New Jersey has one of the highest incidence rates of prostate cancer in the United States, it's especially important to screen, and we really do encourage people in that community to get screened more frequently because we know there is a disparity that exists for prostate cancer diagnosis. PSA testing is recommended around age 50. However, we know that similar to other cancers, if you are at a higher risk, you might be recommended to get more frequent testing, or you might start testing at a younger age, depending on what your healthcare provider recommends. So, looking at what those screening exams are for prostate cancer, there are currently no standard routine screening tests for prostate cancer, but the most commonly used methods are a digital rectal exam. We call this the DRE. This is an exam of the rectum where a doctor or a nurse would insert a lubricated gloved finger into the lower part of the rectum to actually go in and feel the prostate, the surface of the prostate, for any lumps, any abnormalities, anything that might seem unusual. This would oftentimes lead to them getting further testing, like a PSA test, a prostate specific antigen test. This is a test that's measuring the level of PSA in the blood. So PSA is a substance that's made mostly by the prostate. It may be found in an increased amount of in the blood of men who have prostate cancer. There are other things that can cause PSA levels to rise, which is why we don't consider it, a perfect test. But we know that, for example, infections, inflammation, having a condition called benign prostatic hyperplasia, which is just an enlarged prostate. All of these things can cause PSA levels to rise. So this is why we usually recommend with prostate cancer screening further testing to actually confirm the diagnosis of prostate cancer. So if an individual goes in and they have a digital rectal exam and there's maybe a slight abnormality that the doctor feels on the surface of the prostate, and they have slightly elevated levels of PSA in the blood, they may have to get a biopsy done of the prostate to actually diagnose or confirm the presence of prostate cancer. So skin cancer. So skin cancer, we consider the most common type of cancer in the United States. There's really no official recommendation from the American Cancer Society or the USPSTF because, as of 2016 for skin cancer, basically what they recommend is checking your own skin, around once a month, especially if you're at a higher risk of developing skin cancer. We consider, we would recommend you speak with your doctor to understand whether or not you're at a high risk for skin cancer based on your family history, your lifestyle choices, things like that. So basically, they recommend you do, monthly exams, monitor anything that may seem unusual, and then if needed, consult with a dermatologist to, see if there's anything that may need to have a biopsy done on it to confirm the presence of cancer. So like I mentioned, screening for skin cancer could be examination by both the patient or the healthcare provider, the dermatologist. You can do a visual self-exam on yourself in addition to your dermatologist performing a clinical examination, typically, once every 3 months, once every 6 months. So to kind of give you guys some advice on when it comes to doing a visual exam on your skin, we want to make sure that people are taking the time to go over their skin slowly. Take note of any moles, any blemishes, freckles, any sort of marks on your skin, so you can keep an eye out for any changes that happen over time to that mark. If you find anything that concerns you, you're encouraged to reach out to your doctor, schedule an appointment for a clinical examination. So at this point, your doctor is going to check your skin, determine if any next steps are needed. This could be like a skin biopsy to actually confirm the presence of cancer. You might have surgical removal of that mark, mole, blemish, things like that. And we like to give people an idea of what to do in terms of following and monitoring the progression of some of their blemishes, their marks. We call this the ABCDs of melanoma. And this is how you can kind of keep an eye on whether something could be skin cancer. We break this down by A being asymmetry. So check if there's shape of, one half doesn't match the other half. If it's not like a clear and concise shape, this could be an area of concern. You also want to look for the borders, so checking if the border is irregular, if it has jagged edges. You want to look at the color of the mole, the blemish. So you want to see if there are spots within that mole that vary in color. So if you have different shades of tan, brown, black, white, red, is the color uneven? You want to ask yourself these questions when monitoring a specific site. You also want to look for changes in the diameter or the size of the blemish or the mole. So melanomas are usually greater than about 6 millimeters, 6 millimeters. They're about the size of, the tip of a pencil when they're diagnosed. And then you want to see if they're evolving. So you want to check the mole, if the mole has evolved, if it's increased over time. Does the spot look different from the rest of the other spots? Is it changing in that size and color and that shape? Has the mold changed over the past few weeks or months? Try to keep track of these things. So there are always we're going to get into cancer risk reductions in the next slide. There are always risks to procedures. However, in many cases, the benefits are going to outweigh the risks involved in the screening process. Just in the interest of time, I'm going to move into the next slide. So we're going to talk about those cancer screening risk reductions. We'll talk about cancer risk reductions, so things you can do to reduce your individual risks. And then we'll touch upon those things that unfortunately we're not able to control. Thank you, Jenna. So diet. As far as diet, I don't really need to sit here and tell you guys the benefits of a diet high in fruits and vegetables. It's true that we know a healthy, balanced diet is going to reduce cancer risk. Eating your cruciferous vegetables, vitamin D, maintaining a healthy diet, we know will prevent inflammation in the body. It will prevent obesity, which are both drivers for cancer. We want to watch out for compounds that we create when we use high heat for cooking and grilling. These can include things like acrylamides, heterocyclic amines, HCAs, polycyclic aromatic hydrocarbons, PCAs. That's why we have high heat cooking up there, because those things can, increase someone's risk of developing cancer. I mentioned, obesity is, a risk factor for developing cancer. We know that obesity really isn't, one of those black and white issues. There are various key drivers of obesity: eating high amounts of high calorie foods, having a lack of physical activity, overeating, and also genetics. We know some people just have a bigger appetite. People are, more likely to eat more. All of us have different body types, so we know genetic can play a role in that too. But all of these behaviors are increasing fat tissue in the body, and this leads to inflammation and can actually increase our chances of developing chronic disease like cancer, high blood pressure, heart disease. So by staying at a healthy weight, it can actually help us to fight cancer before it even gets on that cancer trajectory. And then exercise, we know physical activity is good for your heart. It's good for your mental state. It helps reduce obesity, which is linked to many cancers, but it also can help to reduce cancer incidence and tumor growth, especially for breast cancers and colon cancers, because what it does is it reduces those growth factors and sex hormones like estrogen and helps to reduce inflammation in the body as well, which we now know will increase someone's risk for cancer. And also alcohol. We know alcohol is actually a carcinogen. So drinking alcohol can increase your risk of developing cancers of the mouth, the throat, esophagus, the larynx, the liver, breast cancers. The more you drink, the higher your risk will be. And that will also increase if you smoke too, use tobacco products. Human carcinogen, that's something we know can cause cancer in humans. So we recommend people, adopt moderate drinking behaviors. It's okay to drink, once per day or a couple times per week. The recommendations actually for moderate drinking is 1 drink per day for women, 2 drinks per day for men. No, don't bank them all into one day and drink 20 drinks in a day. We call that binge drinking, and it's very harmful for the body. Um, you know, when it comes to smoking, I don't need to tell you, how dangerous smoking is, how much it can increase someone's risk of developing cancer. We know smoking is the leading cause of cancer in the United States. And I didn't say lung cancer, I said all cancers. So being exposed to firsthand smoke, secondhand smoke, all of these will increase your risk for developing cancer. And it's not just lung cancer, like I mentioned, also linked to several other cancers: bladder, cervical, kidney, mouth, pancreatic, stomach, throat cancers. A slew of other health conditions can also increase when you do smoke. So we know smoking has the greatest impact on the cancer trajectory. And so when you smoke, you're not only affecting your own cancer risk, but you also affect those around you. And then I've been mentioning, there are certain viruses that can increase your risk for cancer. In most cases, there are ways for us to protect ourselves against viruses, screenings, testing, vaccines, especially the HPV vaccine. We really do encourage people beginning around age 9, 10 years old, if they can, get an HPV vaccine, because that will reduce their risk of developing cervical cancer by preventing the HPV infection. And then there are risks, of course, we can't control. Um, when it comes to exposure to pollutions, that can increase your risk for lung cancer. This could be things like the emissions of traffic, agriculture, chemicals, the smoke from wildfires if you live in an area that experiences a lot of wildfires, factory smoke, things like that. We also have risk for cancer on the job. While we can control for some of our activities, we have to be careful of exposures at work, the places we work, using PPE, gloves, masks, with a respirator filter to reduce the exposure of chemicals and pollutants. And then there are specific jobs that can, of course, increase someone's risk for specific cancers. In agriculture, people may be at a more increased risk for skin cancer due to exposure to UV rays. So we just want to make sure people are aware of those risks in their specific occupation. All right, so sorry I had to fly through the last couple of slides, but I just want to summarize a little bit what we learned today, what we talked about. So we know there are, several factors that can cause cancer. You have those familial hereditary risk factors, those sporadic risk factors that can be modifiable, non-modifiable, and then you also have those exposures in the environments in which we live, we work, we play. So we want to encourage screenings. We know screening can and does prevent certain cancers and can also prevent cancer death. When we catch it early, it's a lot easier to treat. So by avoiding these certain risk factors, you can reduce your own cancer risk. And if you can understand your family history, if you're able to get genetic testing, if you have a family history of a certain type of cancer, just so you're aware of what your individual risk might be. Know your risk. Come on, get screened. Get your immunizations, your HPV vaccines, hepatitis B vaccines. Try to stay active if you can. They recommend at least 150 minutes of exercise per week. It's about 30 minutes a day, Monday to Friday. Maintain a healthy weight by limiting those fast foods, processed meats, increase that fruit and veggie intake. Use sunscreen if you're going to be out in the sun, especially those going to the Jersey Shore this summer. Wear your SPF, at least SPF 30. And then if you're able to, please limit your alcohol use and utilize tobacco cessation services if you do need to quit tobacco use. All right, so that's the end. So I want to give you guys the post test. We're going to launch the poll now. Hopefully your answers, stayed the same. Maybe they changed based on what you learned from the presentation, but I know we're getting close to time, so we're going to launch that, and I'm going to quickly just run through the answers for you guys once we have compliance for the poll, and then I can stay on for a couple of minutes if anyone has any questions or comments.
Thank you, everybody. I see people starting to take the poll. That's very helpful. And I'll just use this time to thank Ryan too for his time. Very, very helpful. I have so many questions. I wrote them down as you were going. Maybe we might not have time to address them here, but it's about detoxes, rebounding slash bouncing and jumping, or hanging as a preventative or a treatment method, for the multiplication of white blood cells. Yeah, just so many things based off of all the great information that you were saying. So thank you for taking your time out this morning to be here with us.
No, my pleasure. And, I do want to highlight how the cancer continuum, from prevention to end of life care, everything in between, it's so complex and it's ever changing. We're discovering new treatments, we're discovering new risk factors, new ways to prevent and detect cancers. And so this is really just scratching the surface as to all the work that's being done in the community, in the research field, to really reduce that risk of developing cancer. And I wish I had more time because, I could get into many, many different presentations just talking about the specific site of cancer, treatment options that are specific to that cancer, ways to prevent that specific cancer. It's just, there's so much information out there, and I hope you guys, at the very least, left here with a better understanding and more of a willingness to learn about those different cancer topics. We really want you guys to be informed and spread that knowledge to your friends and your family so that we're, as a society, a lot healthier and a lot less at risk for developing cancer.
Oh, absolutely. Thank you very much.
My pleasure.
I
All right,
learn
so
always learn more when I hear you all present. So we have
appreciate it.
71% participation, and
It's
that's been that
fine.
way for a bit there. So what I'm going to do is end the poll and
No
thank
worries.
everybody for taking. Do you want me to share the results on this one?
You don't have to. It's up to
Okay.
you. I'll probably connect
We
with you
can do it
offline
now
just to
here.
send the poll results. Yeah, but let me go over the answers real quick. So hopefully you guys put true, true, true. So number one, cancer is when abnormal cells grow uncontrollably. Of course, this is true. Like we mentioned, cancer is when you have that DNA damage that occurs. You have nothing that's stopping that damaged and mutated cell from rapidly growing and dividing, which leads to the formation of those solid tumors. Question two, cancer is the second leading cause of cancer death in New Jersey. This is absolutely true. We know that the only one that's higher than cancer when it comes to mortality is heart disease. And then number three, smoking or tobacco use is the number one risk factor for cancer. This is absolutely true. It's the leading cause of cancer and also the leading cause of preventable death. So we want to make sure if people need it, they have access to those tobacco cessation resources so they can reduce their risk. It's never too late to quit. I know we're short on time. This is hopefully the recording will catch this. This is just our PN brochure, our patient navigation brochure for Screen NJ with our contact information. This is a free service for free navigation for cancer screenings. Anyone can use it. Even if you just move to the area, you need a place to go get a colonoscopy, we can help with that. If you know someone who's facing barriers to getting screened, lack of insurance, lack of transportation, we help with that. So always feel free to reach out to them via phone or email. NJSeed is another great resource in our state. This is a program run by the Department of Health in collaboration with local agencies like us, healthcare systems, and it provides screenings for breast, prostate, cervical, and colorectal cancers for those that are unemployed, uninsured, underinsured, and face those general barriers to getting screened. And they have a facility in all 21 counties. And then lastly, if you guys would take a moment to kindly fill out our evaluation for today's presentation, just a way for you to talk about what your thoughts on the presentation was, what you learned, if you're going to change some behaviors, and then just to give us some feedback on how we can improve moving forward. I'll put it in the chat for convenience sake, but you can also scan the QR code, or you can type in the link or click the link once I type it in. But while I'm doing that, if anyone has any immediate questions, I'd be happy to answer.
Can I ask you one question?
Pete,
Yeah, of course.
absolutely.
I know I should probably know the answer, but immunotherapy. I mean, we always hear of radiation, chemo. What's immuno? Can you talk a little bit more about that?
Yeah, so I won't go into too much detail because we're not necessarily on the point of talking about treatment options since we're not clinical. But basically, the idea about immunotherapy is that you're essentially helping the immune system to fight off the cancer cells. So you're using, different methods in order to strengthen that immune system so that it's targeting those invasive cancer cells. It's basically like commanding the immune system to fight. Again, I won't go into too much detail, but it's one of those things that they're experimenting with in terms of developing new immunotherapies, and it's one of those that's actually very individualized because everyone's different, everyone has different immune systems, and so they try to make it more personalized medicine for those who have a weaker immune system, or just to kind of bolster it and encourage the body to fight it off.
Thank you. I appreciate it.
Yeah, absolutely.
Do you have any other questions or thoughts before we conclude today's session? I'm going to do a quick chat. You can take yourself off mute or put something into the chat box. Okay, I don't see anything in the chat box. I'm going to take this moment to, again, thank you all for being here today. And again, to you, Ryan, for presenting with us. The next session for Our Health to Hold will be on March 26th. We're going to be recognizing Colorectal Cancer Awareness Month, and our SEED team with the Exact Science Grant will be presenting, and we're going to hear from Giovanna, and we're looking very forward to that presentation. Again, it's going to be March 26th. It's going to be at 10 a.m. and we look forward to seeing all of you then. Thank you very much and have a great day, everybody.
All right, thank you, everyone. Thanks for having me. Enjoy the rest of your day.